So, describe the anatomy of the caudal extradural space, which is also called sacral epidural space. So, it's a sacrum is the fusion of five sacral vertebrae in a concave anterior posture. The dorsal aspect consists of the median crest corresponding to fusion of sacral spinous processes. Unlike the lumbar and thoracic, you don't have the spinous process projecting from the sacral and the failure of fusion of the fifth lamina causes the hiatus to form. And it is a U-shaped picture, and this picture tells you beautifully this is the whole of sacrum, okay, fusion of all the things. And you have this hiatus which is formed by that. These are the midline crest with a small rudimentary spinous process you see here and there. And this is the coccyx. Okay? So there is a membrane covering this, which is called the sacrococcygeal membrane, which is nothing but the continuation of the ligamentum flavum, which is present inside the lamina, the upper part of the vertebral canal. So, as all of you know, when you give an epidural at the lumbar space, you cross the skin, subcutaneous tissue, and then in between the two spinous process, you first hit the ligamentum flavum. So that ligamentum flavum continues down here as what is called the sacrococcygeal membrane. And it is a continuation of the lumbar epidural space. So that anatomy is important because if you want a higher level of block, you can inject a larger volume so that the sacral epidural, because it is in continuation with the lumbar epidural, the drug can travel up and you can even block up to the thoracic segments. That is how you are able to reach there. Or you can thread the catheter from the sacral canal into up to the thoracic level because of the continuation between the epidural space of lumbar and thoracic area with the sacral epidural space. And it has some nerve roots of cauda equina leads through the anterior sacral foramen. You can see one nerve coming here. And the dural sac is there at the S3 level in infants and S2 in adults. And the other contents are mainly fat and epidural veins. And in children, the epidural fat is looser and more fluid than in adults. So it causes easy diffusion of local anesthetic agent. That is the reason why caudal takes up much faster in children compared to adults. Now, the techniques of caudal block described to perform can be three techniques, as I said: landmark based caudal epidural, which is the oldest and still practiced by many anesthetists, where you don't have facilities for ultrasound or fluoroscopy. And technically, because it is easier, you can still continue to practice this blind landmark based technique. And it is used, it can be done under topical infiltration or skin infiltration in an adult and the older children. But in smaller children, they may not cooperate. So you may require either a sedation or a GA to do this particular thing. And the position of the patient is very, very important. Whenever they ask you about the description of any regional technique block, you must always remember 4 P's. First P is the position of the patient. Second P is the preparation of the area. Third P is the palpation of anatomical landmark. Fourth P is the puncture, needle puncture, the angulation or the point of entry. So these 4 P's have to be described in your answer: position, preparation, palpation, and puncture. So the first thing is prone position or lateral decubitus position. Then skin is disinfected with antiseptic because it is close to the anus. A strict aseptic precaution has to be done. And then palpation, you can draw a line to connect the bilateral posterior superior spine. We use that as one side of an equilateral triangle, and then connect it to the sacral hiatus, which will make a equilateral triangle like this. So these are the two posterior superior iliac spine bony prominences. So first draw a dotted line like this. Then palpate the hiatus, which will be above the gluteal cleft, and then connect them by another line. You get a equilateral triangle. And then by palpating the sacral conua, which are the two prominences, you can see these are the two prominences that have been marked here. And this gap or the depression between these two bony projections is called the sacral hiatus. And you can use any size between 25 will be too small. You can use from 22 to 23 gauge IM needle, short dual intramuscular. Now you normally don't take a long needle, take a short needle because the distance is not very lengthy. You can easily approach it, as he said, between 0.5 to 1 centimeter depth you will get this. So use a short dual, which will give a more easy feel of that give way. When you puncture the sacrococcygeal membrane, you will get a pop feeling or the loss of resistance feeling. That will be identified well if you have a short blunt needle rather than a very sharp needle which comes with our regular disposable needles. And it also decreases the risk of vascular puncture or the dural puncture. If you use a short dual blunt needle, it will also help to reduce the intravascular and or the subdural injection. And the use of a needle with a stillet, because the sharp blunt needle sometimes may be harder to insert. So you can use it with a stillet to avoid the pouring of the tissues, which will block the tip of the needle, and sometimes even when you are in the space, you will find a lot of resistance to injecting the blood. So you can use it with a stillet. And actually in the UK, they use the IV catheter, 22 Enclon is used. And once you enter the space by piercing the sacrococcygeal membrane, they remove the needle, like your IV needle, and then advance the cannula, the plastic cannula, a little more into the sacral space so that you don't injure any structures or make a vascular puncture. And then after the fourth P is the puncturing technique, where you define the two landmarks, that is the bony landmarks of the conua, and then it is performed between the sacral conua. First introduce the needle at a 60-degree angle. The needle dual is oriented vertically, and after crossing the sacrococcygeal membrane, you bend the needle downward towards parallel to the skin to 30 degrees and advance it. So this picture will give you an idea. So first you start by at a more straighter angle. So this will be 90 degrees to skin. This is 60 degrees. And then you use that. Once the sacrococcygeal membrane has been pierced, you bend it down and insert it further into the extradural space. And this is the actual way of doing it in a real patient. So you can see the angulation here, and then they are bending it to advance it into the space. And after verifying the absence of any blood or CSF fluid trickling out of the needle, then you have to inject the local anesthetic agent. And when you inject it, you should not have any resistance at all, because it's a large open space. It should flow very, very smoothly. In fact, I used to demonstrate to my postgraduates that after connecting the syringe, I used to use my little finger by bending it and then try to push the plunger with that. I don't use it like your normal way of holding it with your index and thumb, and then index and middle finger, and then using the thumb on the plunger. Even if you use your little finger and try to push the plunger, the fluid should go. That is the way it should feel like a with the least resistance. And epinephrine test dose has been given to avoid vascular injury. And if you have an ECG monitoring, that will show immediately changes in the ECG because the epinephrine will cause a tachycardia and increase in the contractility if it is vascular. And if there is a subcutaneous bulging, then it suggests that needle is not correctly placed. It is not entered the sacral canal. And if there is a blood, that means they have punctured a vein. And if there is a colorless fluid coming out, it indicates dural tap. If fluid is cerebrospinal fluid is coming. So if that is happening, you have to abandon. Don't ever try to do the caudal again in that patient, because even if you withdraw the needle and deposit, the drug will enter the subarachnoid space through the hole that you have made in the dura. So the only indication to abandon caudal anesthesia is a dural tap with a CSF lead. And repeated aspirations have to be done while you inject the decided volume. And the methods of administering the local drugs, it can be as a single shot, or it can be through a cannula for intermittent or a continuous infusion later on for both intra and post-operative period. And you can advance the cannula even through the lumbar as well as the thoracic region for blocking higher segments and then helping in surgeries which are done at a higher level. The drawbacks of this extended catheter technique, this is called the extended catheter technique, where beyond the sacral and lumbar you go up to the thoracic region. The one is it can cause a infection. Bacterial colonization is very common because you are going from an area which is close to the perineal region. And the other one is the catheter can migrate through the intervertebral foramen, get caught somewhere, and removal may be very difficult, may get cut, or it may migrate and produce no block at all at their level. And the second technique of doing the block is fluoroscopic guided caudal block. Again, the patient position will be in the prone position. And the lateral view fluoroscopy, the sacral hiatus can be identified as an abrupt drop at the end of a S4 lamina. And the block needle trajectory can be visualized and navigated to the canal when you do the fluoroscopy. And you can use a contrast medium to find the whether you are in the correct space, and then you can try to inject the drug. The third thing is the ultrasound guided caudal epidural. So again, place the patient in prone or lateral decúbito position. The transducer that you use should be between 7 to 13 linear transducer. For obese children or obese patients, you have to use a lesser megahertz curved transducer. And is first placed transversely in the midline to obtain the view of the sacral hiatus, and the sacral conva appear as two hyperechoic structures. And then between the two conva, you will find a band-like hyperechoic structure, which is the sacrococcygeal ligament. And below that, you will find the dorsal surface of the sacral bone. So between the two cornua, below them, you have two structures to be identified. One is the sacrococcygeal ligament, and the second is the sacral bone. And the sacral hiatus is between these things. So you can see the transducer probe is in the transverse position like this, and you are seeing the two sacral conva, and this is the sacrococcygeal membrane, and below that you have the sacral bone. So in between these two structures is the sacral hiatus. So first identify that, and before you put the needle, what you have to do is you rotate the transducer to 90 degrees, the vertical position, and then when the needle enters, you can easily see that, and the needle entry position is seen. This is the sacral hiatus. So insertion should not be done in this position. Insertion should be done when you turn the transducer and identify this in the lateral view like this. So in plane technique is used, and the block nodule can be visualized passing through the sacrococcygeal ligament, and you can deliver the thing. Now this is the ECG with which you can identify the presence of, injection intravascularly. If epinephrine containing solutions are used, you can see the changes that happen in the T wave, which is very small initially, becomes more and more taller, and more T wave amplitude keeps on changing when there is an intravascular injection. Along with that, you will find some increase in the heart rate also. So what are the various doses required? It depends on the level of block that you want to achieve. For sacral block, 0.5 ml per kg of 0.25 or 0.25% bupivacaine is commonly used, or you can use levobupivacaine or bupivacaine nowadays, which are less cardiotoxic. For inguinal block, you require 0.75 ml per kg. For lower thoracic, that is up to umbilical level, T10, you require 1 ml per kg. And if it is higher than that, you have to use 1.25 ml. But when you use more than 1 ml, you have to reduce the concentration further from 0.25 to 0.125 or 0.2, like that. So that you don't exceed the total safe limit, which is 3 milligram per kg body weight. And different drugs that are used are bupivacaine, ropivacaine, and levobupivacaine at the concentration of 0.25% or 0.2 or 0.125, depending upon the total volume that you use. Indications and contraindications, of course, what we said is it's all indicated in urologic, orthopedic procedures, abdominal, pelvic, genital areas, for circumcision in male children, as well as herniotomy or herniorrhaphy in small child. With all the local lower limb procedures, we can use that. And it is very useful for daycare surgery, especially when you use a short-acting drug. You can discharge the patient easily, and not much of hemodynamic instability will happen when you use Caudal, because the level of block is much lower, and it is used in acute and chronic pain conditions also. So it is one of the part of the treatment of chronic pain. So pain specialists use this for injecting steroids or local anesthetic into the caudal space for low back pain and sciatica and all those conditions. And catheter insertion can be done for surgical procedures in the higher abdominal or thoracic areas, and also for giving post-op anesthesia. The contraindications, which are common to any regional technique like coagulation abnormality, local infection, and neurological disorders, they are all the contraindications for Caudal also. And if a patient has cutaneous anomalies like angioma, hair theft, or nevus or dimple in the area of a hiatus, then they may have some inherent neurological problem. So don't try Caudal on them. So it is one of the contraindications, because they may have what is called a tethered spinal cord, adherent spinal cord, which may later on lead to permanent neurological deficit. And the adjuvants that you can use are preservative-free morphine, clonidine, dexmedetomidine. Preservative-free ketamine is also being used. So these are all to be used only in inpatients. It is not to be used in daycare. So if you are planning to do a circumcision or a hernia as a daycare procedure in a small child, do not add any preservatives, because that will unnecessarily prolong the later respiratory depressions can happen. So if a child should be under observation if you are planning to add in additives in the local anesthetic. The complications, common complication is dural tap and vascular cord puncture, exceeding maximum dose causing local anesthetic toxicity, delayed respiratory depression, urinary retention. And what is whoosh and squish test? You know, Aravind, did you read about this?
Sir, no.
No, okay. Anybody else who read about it or who has an idea about it? See, earlier
Sir,
to
we
identify,
inject.
who's answering?
Sir, we inject a amount of air
Hmm.
and hear it with the help of the stethoscope, so that we can hear the sound of the wind passing
Very good.
through the canal,
Hmm.
and that is the confirmation for the caudal which we are
Caudal
trying to
block.
give.
Fantastic. And is it being regularly done? At what level you will auscultate?
Sir, around L3, L4.
Lumbar level. Lumbar or lower thoracic. Very good. So that was one of the earlier methods of identifying the presence of the needle in the sacral canal by, as he rightly said, inject 2 ml of air after you insert the needle to the sacral space after you got the feeling of piercing the sacrococcygeal ligament. You take 2 cc of air in a syringe and then push it, just like you are identifying the presence of your NG tube, putting it into the stomach. You inject the air and then auscultate and find out whether it is in the stomach or not, isn't it? All of you are familiar with that to identify whether you have passed the NG tube correctly. Same way, you inject not large volume like that, but only 2 ml and auscultate with the stethoscope over the lower thoracic or lumbar region, because the space is continuous with the sacral epidural space, as I told you earlier. The air will travel and you get a feeling like that, and the needle, the air passes through that. But this later on produced some neurological complications, because this air stretches the nerves and then complications happen. So they replaced it by using 2 ml of saline or local anesthetic. Instead of air, they use that. And when you do that also, you get some sound. So that the earlier air injection is called whoosh test. And later, when it was modified to use local anesthetic or saline 2 ml for identifying the sound, it was called swoosh test. Okay. So that is how injecting 2 ml of air into the caudal epidural space resulted in a whoosh sound. It was verified through a stethoscope held over the thoracic or lumbar spine. After reports of neurological and hemodynamic side effects, the technique was refined into injecting local anesthetic or saline, and then it was modified as swoosh test instead of whoosh test. Okay? So these are the things you have to know about caudal epidural. It is one of the very useful techniques that every one of you should learn well. It will come very handy when you handle a pediatric case. Okay? Right.
Thank you.